Okay, we're going to go ahead and get started in respect of everybody's time and punctuality. So again, welcome and thank you all for joining us on behalf of Health and Temperance at Normandy Avenue for this week's health message or talk update. My name is Darrell Harrington, and I'm going to be talking to you all a little bit about COVID-19, a little bit of update, particularly since there's been a bit going on in the news. And we'll have plenty of time for questions and answers. I've prepared a brief presentation. Before I switch over my screen to the slide presentation, maybe we can just bow our heads for a quick word of prayer. Most gracious Heavenly Father, we thank you again for another day, for a new year. Although with some carryovers and challenges from the last year, just more opportunities for us to prove our faith and experience the love and affection that you have for each one of us. We thank you for taking us through 2020 and bringing us into 2021. And we ask now that in the next several minutes that you would be with me as I share what you've impressed and given to me. Be with those to keep their hearts open and their minds willing to digest so that they might be enriched and live stronger and safer lives in you. In Jesus' name I pray, amen. All right, so with that, again, welcome. A few folk have joined while I was on in the prayer, and I'm going to go ahead and switch over to my shared screen. If there are any challenges or problems, please let me know, because we've had some technical difficulty, but things should hopefully be pretty smoothly. Okay, I hope that's projecting fairly well. So we're going to talk a little bit about coronavirus, and as usual, we'll talk a little bit about some of the trends, just so that people are on the same page. And I know that many of you have been watching some of the trends and follow the trends. I've given you a couple of I think, really good websites that I think are fairly accurate and have easy navigated sort of numbers for U.S., statewide, and even local statistics and numbers, if that's useful. We're going to talk a little bit about the vaccine, and we're going to talk a little bit about the new strain of virus that has been reported over the last week and a half or so, and then open up for other questions that you might have related or unrelated to those topics. So just jumping right into this as a reminder, I always like to remind people, so we never know when we have new listeners, that this is a virus which spends on average about 8 days replicating, meaning incubating, if you will, after you are exposed, if susceptible, before you become contagious or even develop symptoms. And this is extremely important, again, because what it means, particularly in this time that we're in now, is that so many people that we come across are unknowingly or may unknowingly be contagious, and we don't know about it because many actually have no symptoms. And so we spend a fair amount of time just developing enough virus to become contagious when we're completely asymptomatic. And then we spend some time here in the red, as I mentioned here, just being contagious, but having no symptoms. And then about 50 to 6% of the people actually have symptomatic disease, somewhere between 15 and 40%, depending on the age, and comorbidities, may have no symptoms whatsoever and spread the disease. And I'll talk a little bit about why this is so important, particularly in Los Angeles County in this current surge. So if you again look at this, you could be contagious, conservatively speaking, potentially for up to a month after you have become contagious and or mildly symptomatic. So even though we have these days of these 7 and 14 days of quarantine per se, as I talked about before, those times were selected because it covers the majority. It does not cover everyone in terms of the risk of being contagious. Again, spread is quite simple, and therefore our simple understanding of spread means that if we're careful and we just simply take care of those 3 Ds, Andrea, you're going to remind us what those 3 Ds are, right? What are those 3 Ds? Anyone remember the 3 Ds of spread and prevention?
Distance, density.
Distance, duration, and density.
And density. So if we can remember that the highest risk periods for us is when we're in close proximity to someone, particularly without a mask, when we are in an enclosed space with that person or persons, right? And for a prolonged period of time. So if you can reverse engineer that, you can reduce your risk of getting it. And if you can maintain these 3 Ds, you can reverse your risk of spreading it. Okay? It's very, very, very straightforward. I know it's a little challenging, but I like to just, again, remind us of those 3 Ds. Okay, let's go right into, we're going to go right into the, some of the data that I'll share with you real quick. So if you again look at this sort of map, and this is the map from COVID Act Now website, and in the dark red or almost sort of, it looks almost brown, looks at the states with severe outbreaks. And right now, California and Arizona are at the top of the list. California, and particularly Los Angeles County, is one of the highest in the entire country. And has been that way for some time. Does anyone have an idea why that is the case? And without anyone talking, go ahead.
Oh, are you asking why California now is at the top of the list?
Yeah, and why? And California is at the top of the list. And I'm just going to give you a hint. It's because of LA County, primarily, that the California is at the top of the list. And so why is LA County such a hot spot for COVID-19? Does anyone know?
Because it's densely, sorry.
Then we have a high number of cases in the nursing homes.
Well, that's true. In the very beginning, in the spring, like in the late winter and spring, nursing homes were at the forefront of this, and it just ran rapid through the nursing homes. But nursing homes got their act together fairly quickly. And so by early summer, nursing homes were very strict with visitors, and they were very minimum to limited cases in any nursing home. So the reason now, anyone else?
Because there are a lot of people?
Yeah, and it's actually because there are a lot of people in a certain way. So there are a lot of people in New York. New York isn't that bad, right? There are a lot of people in Boston, right? It isn't that bad. We can go through one metropolis after another, Chicago, etc. And the primary reason why in LA, Los Angeles County, it's
homeless.
Nice
Homeless.
weather.
No,
we
no.
move around a lot.
Owner fatigue.
Okay, all right. So I'm glad for the participation. Let me just address both of those. The homeless population has the least prevalence of COVID-19. Okay. So the homeless right now, things are being turned upside down. They're doing better than people who are in houses. Okay. Now, someone said being, the sort of the weather. Well, the weather actually promotes mixing. So this is very true.
Yes. True.
So it does promote mixing, but what really gets us is that then with the mixing and the exposure, Los Angeles County has one of the highest densities of household. So something called household density is the biggest challenge in Los Angeles County, meaning we have per square foot of an apartment or condo or house, on average, there are more people living in a home or a house in Los Angeles County than in many other counties in the country. In this county, we have multi-generational living. That's actually very, very common, particularly as part of our Latino or Latinx community. Okay. And so when you have a household density that gets above 3, and so now you're at 5, 6, or 7, or 8, and you're actually in a small place, it could be an 800 square foot apartment, a 1,200 square foot home. All you need is one person to be out and about because it's nice in California, right? And then they get exposed and they're relatively asymptomatic because they did something, you know, maybe they're in Orange County, maybe they had a friend in Orange County, they're just hanging out, or they went to visit somebody and, you know, everyone feels good. So for 2 hours, they have lunch and they talk, they're asymptomatic, just spreading it asymptomatically. But then that person who otherwise is low risk for a bad outcome goes back to their multi-generational high density household and multiple people get it. Okay. And one or more of those individuals is high risk. And so that is what we've been seeing from a public health perspective. And that's why at my hospital, like last night, I was at work till just about 8:30. After I got off a call at 5:30, I thought I was leaving. And then I got a call to go directly to the emergency room because we were closing our emergency room. We're in a level 1 trauma center. We were closing our emergency room to trauma, which is a big deal because that means that the emergency room is so busy with other things that you can't take care of someone who's in a car accident or has a gunshot or a major stroke who's right next door to you, right? And it was because of COVID, okay? So in Los Angeles County, the idea that we have high household density and people are continually mixing and doing things despite a quote unquote shutdown amplifies this this pandemic more so than in a cold state, for example, where even if they have multiple people, the weather keeps people in, right? And there's not as much mixing and contamination, if you will. So it's challenging, but this is one of the reasons why we have this sort of persistent problem, and it's why our Thanksgiving surge is going to now just be matched probably only by our holiday / Christmas New Year's celebration, which actually we have reports of already. Many people celebrate it behind closed door and in public. Okay, so I showed you this data before, again on COVID Act Now. You can look at the metrics of daily new cases, infection rate, and positivity ratings. Those 3 metrics that determine who's at the highest, right? And right now, the sort of number 1 place, if you will, when you look at all 3 of those metrics is Arizona. But California, or particularly Los Angeles County, isn't too far behind. Now, one thing I can tell you, even though I'm showing you a static picture of today, all of these numbers, which are the daily number of new cases per 100,000 across the US, are lower now this week than they were last week. The infection rate, which is the second column here, okay, these numbers are all lower than this week or today than they were last week. So things are still moving in the right direction, but the genie is out of the bottle, and it's still very difficult to keep up, even with the number of new infections. Even though the rate of new infections may be declining, the total number of new infections is still high. So that's actually leading to what you'll see here. This is actually just Los Angeles County and the number of cases. And what you see here is something that looks like we call a pseudo plateau. We recognize that probably over the next 2 weeks, this is going to be going up again. And it's going to be likely going up from Christmas and New Year's. And so, again, we've had still over the last week some record days of new cases in California. So don't let something like this sort of false plateau, fool you to think that we're sort of over the surge, because we actually are far from it. This is actually looking at the number of deaths, which again accumulate and on average over 7 days. And it's getting more difficult because it's becoming more difficult to care for people in the hospital. And so let me just say this right now. Last night, I was called down to the emergency room because we were treating gunshot wounds in the hallway. And we were treating gunshot wounds in the hallway because we had no regular trauma beds for those patients.
Wow.
So I'm saying this to you all. Right now, not only is it the time to stay safe from COVID, it's the time to stay safe from any sort of illness or accident. Because the hospitals, and not just my hospital at Harbor or at UCLA in Westwood, but many of the local community hospitals have very limited capacity, period. And so if you're really, really sick, you have to go to the hospital. But do your best to be compliant with whatever medications or therapeutic regimens you're supposed to be on. Be very safe out there in terms of watching yourself for falls or car accidents, because if you were to get into an accident unrelated to COVID, getting medical care and treatment at the hospital now is difficult and different than it would usually be, particularly during this time of surge. You can see the rate of hospitalizations continue to go up, and the rate of ICU utilization has continued to go up as well. Okay, we're not at a point yet where we have run out of ICU beds per se, but we're getting there, and we're getting there quickly. Okay, and again, this is just Los Angeles County. So I just wanted to show you that data. And when you compare LA County to Orange County to Riverside County, all are going up. LA County may be the worst in terms of normalized data per 100,000, but everyone, our sister communities, our sister counties, are equally seeing a rise in hospitalizations. Okay. So again, Governor Newsom's plan for reopening is sort of like not a chance, but Governor Newsom's sort of lockdown, if you will, and enforcement of that is really left to the individual responsibility of citizens and communities, because there's literally no enforcement whatsoever from law enforcement or public health at this point. Any questions about that before I go into vaccines? And again, I know people become not immune, but tired of wearing a mask, and they just want some semblance of normality. But things are real, and they are continuing. Okay.
I have a question.
Yeah.
Yes, I heard one doctor said that the virus is real, but the numbers are not real. It's that if somebody comes in and they die from a gunshot wound, and they will say that they died from COVID. So that is what is.
Well,
so I don't know.
Well, here's what I will tell you. As someone now back in the saddle of seeing patients and being in the ER and being involved in what we call triage decision making and making hard decisions and anticipating that we may have to say choose between who gets what, right? Therapy or resource. When I walked through the emergency room last night, and our emergency room was no longer an emergency room, it was basically a large ICU, and that large, otherwise state-of-the-art emergency room was just a bunch of people who had COVID on ventilators in the emergency room. What I would say to anyone who thinks that it's not real or that we're overcounting is that it is very, very real. And that I see every day and look into the faces of people every day who have this disease and see loved ones and family members who bury people who are suffocating because we can't provide enough support for them for their lung function because they have succumbed to this disease. So if there is a padding of the numbers, there's a padding of the numbers which is so small that it still doesn't take away from the real burden of disease and the real experiences that are occurring every day in the hospitals and the community surrounding us. So not to minimize anything you said because there may be some of that. Death certificates are always potentially flawed with accuracy. But I'm telling you, because I'm seeing it every day, that we have a number of patients every day who are dying from COVID, not with COVID, but from heart failure, or not with COVID, but from pneumonia or a stroke, but from COVID refractory to therapy or support. I'm seeing that every single day. So I hope that answers your question. And you have to think about always why someone might be saying that. And if someone is saying that and they're leading with that, it's, sometimes it's out of fear, but the other reason that it's happening is because the denial of, that this really is a big problem to some degree is the only thing that we can sometimes do to comfort ourselves from just living in the constant state of anxiety or fear. I would rather meet this with reality, right, and then take responsible action.
I have a question.
Yeah.
This said O positive, O blood type is immune to the virus. Is that?
Yes, that's a really good question. O blood type, as you know, there are really two primary blood group antigens, if you will, A, B, O, and then RhoGAM that are attached to blood typing. And so we talk about A positive, B positive, and O positive, and then all those being like AB negative, AB and O negative. O blood type, there seems to be an association where people who had O blood type have fewer infections. So that's an association relative to the number of people who are O blood type. So if you took all the blood types and you said, here are the proportion of blood types that exist in our, in the country or in the community, and then you say, here's the proportion of A, B, and O, et cetera, et cetera. The O type is underrepresented in people with COVID. But there are plenty of people who have blood type O who have COVID. So some people have taken that information to say, because there are fewer people with blood type O with COVID, that somehow it may be protective. And there may be something to that. But what the public health people have said consistently, and what the immunology people say consistently, as long as we have plenty of people with blood type O getting COVID and dying from COVID, we would not interpret O being protective, okay, or protective enough, okay? So it's a very good question and observation, because you can imagine some people with blood type O saying, hey, I'm blood type O, therefore I don't need to get the vaccine, right? Because I'm protected from my blood type. And I absolutely would not say that at all. So it's a great question.
Okay, thank you.
David, I have a question.
Okay.
I mean, Daryl, I'm sorry, not David, Daryl.
Yeah, that's okay.
I'm sorry, I had already typed it, but since I have a chance. I tested positive because I was in touch with a friend of mine whose husband had contacted coronavirus, or he tested positive, and all he had was a headache. And then a few days later, or a day or two later, his headache was gone. And then his doctor told him he doesn't believe that he had it at all. But then his wife came down real sick. And I came down sick also with like the same kind of flu like I had last year with the cough and sneezing and all that kind of stuff.
Sure.
Now it's going away, but my question is this. A few days ago, when I got up, I would walk a little short distance, but then I had to stop because I was so winded. I had spent about most of last week I was spent in the bed trying to get as much rest as I could. So will this, it's not shortness of breath, it's just feeling winded. Will this go away as the days progress, or what?
Yeah, so let me talk a little bit about that real quick, and then maybe I'll come back to it when we get to some question and answers, because I want to get to the vaccine and the mutant virus. But just quickly, for everybody, yes, I think it's really important to remember, like any disease or any infection, how an individual manifests that infection varies quite dramatically on a number of variables, like how much you're exposed to when you're exposed, your own immune system, comorbidities or other things that you might have, variety of things, right, that actually influence what symptoms or signs you might have as a manifestation of your infection. So there are a lot of people who have virtually nothing. There are people who are deathly ill. There are people who it's just like a cold for them. There are people who have more of a flu. There are people who have a headache. There are people who have just diarrhea. There are people who have just a fever, and that's it. And so it varies from person to person. And we talked a little bit about this, months and months ago when we were initially talking about COVID. And it's not just a simple short-term symptomatology, meaning that there are people that we now know who can have symptoms, get better, and then the symptoms come back and the symptoms may be the same or different. So it can be even prolonged for some people, meaning that the symptoms can actually be variable over week, 2 weeks, 3 weeks, and not just a simple course. Having said that, those individuals who do develop a little bit more a progression of symptoms with fatigue and or shortness of breath, that usually does take some time to resolve. It can linger not just for days or weeks, but has been known to linger sometimes for months before either resolving or getting considerably better. One of my employees, who's very young and otherwise healthy, had COVID early on, and she's a very active young lady, and she now about 4 or 5 months later is now just getting back into taking long walks without getting winded. And so it can take some time. The most important thing is not succumbing completely to that and allowing yourself to be sure that you're getting upright, you're expanding your lungs, and you are walking, but to take it easy because you are and your body is trying to recover and convalesce from the illness. So I'll come back to that a little bit. I do want to get into the vaccines and the mutant viruses for a few moments, but it's an important question to come back to. So,
Okay,
yep. So let me first talk about this new strain. And so what do we know about it? And what we know is that we believe it came out of the UK, probably didn't come out of the UK, but that's probably where it was first recognized. It probably actually came someplace else. And it's called B117, okay? B1117 is a strain that is not a surprise to us. Viruses, DNA and RNA viruses, but particularly viruses that are running amok in a community or society, do their do their best to adapt to the challenges of a smart, technologically advanced society. So what do I mean? Like we are a fairly medically advanced world and society, and these viruses are just trying to get along. These viruses are literally just trying to survive, just like we're trying to survive. And believe it or not, viruses in general, just like bacteria and fungi, bugs do not like to kill their host. So they learn over time how to coexist. So the first strain, or this strain that kind of came out first, sort of a little stupid, doesn't know that it's actually killing the host and killing itself, right? But it has to learn over time. And what we know is that over time, viruses will adapt and learn how to not only live better, but allow their host to live better. So this new strain, B117, we know is more transmissible, which typically happens in a new mutant virus, right? Because it's just trying to survive. So it's going to be more transmissible. And it's got probably 40, 50% additional transmissibility. Some say up to 70% more transmissible than the parent virus, meaning it will spread more rapidly. But it is not as virulent, meaning that it will not cause as severe of symptoms in a given host or patient, and the mortality associated with the virus doesn't seem to be as bad. That doesn't mean that still people won't die from it, but again, compared to the parent virus, the original SARS-CoV-2, it is not as virulent or severe, although it's more easy to catch with a very similar mechanism of transmission. What's different about this virus is that the virus proteins that allow it to hook into the back of your throat, your nose, your lung, it's more sticky. It clings more. So it's a little bit more resilient when you cough or when your normal mechanisms that would fight viruses or infections would clear it. This is actually a little bit more tenacious, okay? Now, the question about susceptibility to the new vaccines that we've developed, so far, at least the vaccine scientists and the immunologists who have actually looked at this strain and studied it so far, recognize that the spike protein that the vaccine is primarily geared to as a target is still preserved in the B117, meaning that they believe that it in fact will still work. And there's no evidence right now that the current vaccine will not be effective. So all evidence currently points that the vaccine will still be effective to this new strain. Okay, we have no evidence that it will be less effective or not effective at all. So it's more transmissible, it's less virulent, and it still is susceptible to the two vaccines that we actually have available and approved in the United States. Okay, its first was sort of put in the news in Colorado, as you all probably know, but it's already been identified here in Southern California as well as in Northern California. So that new strain is here already. And it will work its way through the community in terms of speeding up transmission in our community and our population. But it's already here in California. Okay, documented cases of the new strain. All right, any questions about the new strain, B117?
Yeah, so if you already have some form of the virus now, can you catch this B117 also?
Oh, that's a great question. So we believe, most of the people believe that the primary proteins, the primary structure of the viruses are close enough that your body's immune system, if you mounted an immune system against the original virus, that as long as that immunity exists, you will be protected against this new strain. But remember that we believe that your immunity for the virus will last somewhere between 6 months and a year if you mounted a good immune response. There are some people whose immune response will not last as long, but in general, most people believe 6 months to a year, if you have a really good immune response, you'll be protected not only from the original type of virus and reinfection, but also this new strain. So really, really good question. If you developed an immune response, will you be protected against the new strain? And the answer, we believe strongly, is yes.
Okay.
Okay, great question.
I have a
All right.
question concerning that too, Dr. Harrington.
Sure.
Because if I tested positive, so I believe that I have antibodies. So why are they saying that my antibodies would last like around 90 days when it's my own body that is generating or protecting me, but the vaccine, how long is that going to last? That's artificial. Why would the
Yeah.
artificial virus vaccine last longer than my own body's antibodies?
Okay, so I'm going to talk a little bit about vaccines, how vaccines work, just in a few minutes, and hopefully that'll answer your question. Okay, so just hold on to that question, because what you're asking is so valuable and so important, not only in us understanding what it means if we were previously infected, but the question about if I was previously infected, should you get the vaccine, right, comes up as well. So I'm going to come back to that because they're both related and very, very important. So let's talk about the vaccine a little bit, and I'll get back to your question in explaining how the vaccine works, et cetera, and why it's unique or different. Okay. So the challenges that we've had, weren't just in the target development and all this, because we moved through this sort of normal, prolonged period of vaccine development, right? We moved through that very, very quickly, right? I mean, this is sort of Operation Warp Speed. The manufacturing process, development, and all that's been really great. We have not anticipated, or at least a lot of the states have not anticipated, storage and distribution challenges. And it's why, as you've heard on the news, we've done such a poor job with distributing the vaccine across the country right now. So there's just vaccine just sitting in freezers, vaccine waiting to be sort of pushed off the assembly line into trucks and delivered. But because of infrastructure, because of poor planning, both at the federal and state level, we are off the mark target in terms of vaccine distribution. And I can say more about that, but I'll just leave it at that for the time being. Having said that, some of the challenges that we have faced really have to do with the sort of plethora of information, right? And as I mentioned, there are two vaccines that are currently approved, Moderna and Pfizer in the US. AstraZeneca was already approved in Oxford, and then we have some that are approved in other countries as well. I told you guys before that there are typically 4 types of vaccines, right? A killed or weakened virus, a viral vector, a nucleic acid, which is what we're talking about here, and protein-based. And so the 2 types of currently approved viruses, vaccines that we have right now are nucleic acid mRNA vaccines. The M stands for messenger RNA. And I want to talk a little bit about how that works and sort of why that's important in just a moment. Again, the biggest differences between the 2 that are approved, between the Pfizer and the Moderna, they're both are mRNA, has to do with storage and transportation. Pfizer is delivered in large quantities and must be stored at much more stable, lower temperatures, making it very difficult to get the Pfizer vaccine to more rural or remote areas. So the Moderna vaccine is likely going to have a role in trying to reach rural communities or sort of more remote areas where they don't have such availability of deep freezers, okay? So that's just the reality, and you may not have a choice because it's just not feasible. But in terms of differences, they're really about the same. With regard to how they work in terms of immune durability, before I explain the actual mechanism of action, what we know is the reason why you get 2 doses is because the first dose, and this is important, because this sort of goes to the question of why innate immunity versus vaccine immunity is different. If you just got 1 vaccine dose, we know that people will develop somewhere between 50 to 55% antibody effectiveness or immunity. With the second booster dose, which is the second dose, an equal dose, about 21 days to a month later, you now go to 95%. Okay. Now, why is this important? Well, it's important because when you get exposed, so Janice, you said, well, I have my own innate immunity. Well, when you get exposed to an unspecified amount of virus. That unspecified amount of virus may or may not be enough to give you an antibody response equal to plus or minus like a 1 dose of vaccine versus a 2 dose of vaccine. So we know that many people still are susceptible to illness, but do not have a really, really strong antibody response, meaning that they actually may have less profound antibody production that won't last as long. So to your question, Janice, the concern is that we know that when we look at studies of people looking at antibody production in people who've had COVID, and we already have this data, that we know that there are lots of people whose presence of circulating antibodies for COVID begins to decline rapidly after 3 months.
So
Okay.
would I just only need a booster then instead of the full 2 doses?
So we don't know that. We don't know, that has not been studied. No one studied intentionally just taking a single dose after being positive before. The only thing we know and what we've made recommendations about with regard to previous infection and getting a vaccination is that you should likely wait 90 days between your confirmed infection date and getting a vaccine, because you really don't want, there's a theoretical risk of what we call sort of a hyperimmune response, right? And so that's a theoretical risk. And so the recommendation currently is to wait 90 days after you've had an infection, a confirmed infection, before you would get a vaccine. What we do know, compared to sort of a random infection, is that if you get your second dose of a vaccine, those antibodies are more durable and are more profound in terms of your body's response on average per person than just your routine exposure. And we know that it lasts at least 6 months. We've seen that for at least 6 months, and the clock is ticking because we actually have, sort of longitudinal follow-up studies, if you will, of people who have received the vaccine earlier in the year. So that's sort of the rationale for sort of your question, this idea of, hey, our innate immunity versus the vaccine, okay, at least in the long run, okay? One of the ways if you really were trying to avoid the vaccine in doing that would be to get a quantitative evaluation of their antibodies. And very few labs are doing that, right? Very few labs are actually measuring quantitatively how many antibodies you have in your system for COVID-19 after an infection. That's a little bit more of a research lab as opposed to a routine lab that could be ordered at your doctor's office.
So
Okay.
Right now, they're not testing anybody that has had the virus and recovered. They're not doing any research on them right now?
Yeah, there are some studies that people could enroll in as a research subject to either follow the natural history of your COVID infection or follow the natural history of your vaccine immune status. So there are a number of studies that are available that you could actually enroll in, and almost all of them are sponsored by NIH. So you could go to the NIH website and look at, it's like dozens and hundreds of studies, and see if there's a study in a study center or site near you that you could enroll in if you're interested. But that would be part of a formal study. It's not done as part of your healthcare at Kaiser or UCLA or any place like that. So let me just take a moment. I want to make sure we're all on the same page with how the 2 vaccines that are approved work, okay? The first statement I want to make is that the vaccine is not DNA. It's mRNA or messenger RNA. And I want to explain the difference to people about DNA. DNA, a DNA gene, if you will, is what people would like to describe as our blueprint. Okay, it's how our organs, our cells, our tissues, everything about us that's built. It's the blueprint. It's the plans for how that happens. And so when something's damaged or when it needs to be repaired, it goes back to these blueprints that have been imprinted in every cell in our body. They are, relatively speaking, permanent. Okay? We are DNA animals, DNA creatures. There are such thing as RNA creatures. Okay? And a lot of those actually are bugs. Okay? Like viruses, etc. Now, mRNA is not the same thing. mRNA is called messenger RNA. And every human being has naturally occurring mRNA in our bodies. And what mRNA does, if DNA is the blueprint that actually tells, hey, this is how I want you to build the house. mRNA, a lot of people will actually liken it to, is like the contractor you hire to build your house. Does that make sense? So the blueprint that's permanent is the DNA. That's in every cell. The RNA, or the mRNA rather, the messenger RNA is the contractor we hire to build our house or to build our chimney or to build our room addition. And we can fire those contractors. Those contractors come and go. Those contractors are not permanent. So that's a very important part of these vaccines. People have repeated, oh, I'm worried about this getting inserted into my cells and becoming part of my DNA. That's not true. That's not possible. That's not how mRNA works. mRNA slips in, it gets carried in with a vehicle, okay? In this case, it's called an adjuvant. Our cells see this contractor that says, okay, let's start building a chimney or let's start building a room addition, and it builds. Sometimes it builds, sometimes it doesn't build. And then mRNA goes away. The contractor is sort of fired, if you will, or retires. That's it. It's not a permanent part. It does not become a permanent part of your cells. And not every cell of your body can even respond to or envelope or ingest that mRNA. So only very specific cells see the mRNA. And what the mRNA is a contractor who only builds certain sorts of bathrooms. And that certain bathroom that's building is the spike protein that's been identified on the virus. So on the COVID virus, this pathogen in this slide, right, we found a protein, in this case an antigen determinant, but a protein called the spike protein, which we determined is an important protein in causing the problem. We then find this protein and we engineer a contractor, or an mRNA, to code for or help us to build that protein in our bodies. And so what happens is, yeah?
You're going to put it on the back one. It's so slow.
If you could put yourself on mute real quick. Thanks. And so what happens is the vaccines now are these little contractors, these mRNA contractors that we inject as a vaccine that then go to specific cells and make the specific bathroom, or in this case, the contractor makes these spike proteins. And these spike proteins are now foreign. And our own immune system sees these spike proteins and says, wait a minute, you don't belong here. Let's get rid of you. And so we have cells in our body that go and recognize, they're called macrophages, and they go and they recognize these foreign proteins and they digest it. But as they digest it, some of these macrophages are called memory cells, which you see here, and they're not in the heart or whatever, that's just in the body circulating. And these memory cells now develop these antibodies on the surface, which now become, as we say, lookouts, just in case some more proteins are seen. So we also have this redundancy in the immune system called B cells and T cells, and they function to amplify this response. When you get one vaccine, you get a certain level of response. When you get the second vaccine, you amplify or maximize that response. And so now what you'll end up with are these antibodies that are just hanging out, waiting in the background. And these B cells and memory cells are just waiting so that when you now get exposed to the virus, you already have your immune system which says, I know you, I've seen you before, you don't belong here, get out, or I'm taking you out, okay? And then it sort of attacks this foreign molecule, now in the form of a virus, and prevents you from actually getting the disease, right? So that's in a nutshell how it works. mRNA is not DNA. The vaccines cannot get integrated or incorporated into your DNA. They will not become a permanent part of you. They help your body recognize what the virus would be if it should come in your body and prepare it to fight when and if you get infection. Okay, that's how the vaccine works. And so far, we know that the immunity lasts probably at least 6 months and counting. Okay. Questions about how I explain the virus to work or the vaccine to work? Any questions about that?
I do. So let me understand. Oh, I'm winded. I'm sorry. Once you get vaccinated, I mean, as kids are growing up, we got vaccinated for different things, and they're supposedly supposed to stay with us for the rest of our lives. But with this vaccine, huh?
It depends, right?
Supposedly.
It depends on the vaccine and the virus or what you're getting vaccinated against, right? So if you vaccinate someone against something that has a very low prevalence in society, then oftentimes your vaccine, after you've gone through your boosters, etc., your protection is lifelong because your exposure is very low. Okay. When something, and I'll give you a good example, like tetanus vaccine. Okay.
Right.
Tetanus vaccine is recommended to get boosters. Why is that different than like polio or mumps or rubella? It's because our exposure to tetanus, right, particularly if you're playing or you do work or construction or you might have accidents, our exposure to the tetanus bacteria is actually, and tetanus is still around in the community or in the atmosphere, in the soil, because it's still prevalent. We actually have to get boosters, right? So if measles ever became a pandemic again, we would all, I guarantee you, get a measles update, right? Our childhood measles vaccine would not be enough. So a lot of this has to do with how prevalent and persistent the virus or the bug that you're getting vaccinated against is still in the community or in the world. The more persistent or prevalent it is, the more likely that you would actually have to get ongoing boosters or vaccinations, right? As well as how frequently or how stable the virus is with regard to mutating. The influenza virus mutates very frequently. And because it mutates so frequently, that's why there's a new vaccine almost every year. Okay, so I hope that makes sense.
No, I didn't finish asking my question.
I'm sorry.
It's okay. I just wanted to understand that with these new vaccines, they're not guaranteed to cover us like you just described with the measles, mumps, and all that kind of stuff we had as kids. It's only for a short period of time you have to get back. Are you saying we have to get vaccinated every year after that if we decide to get vaccinated at all?
Well, that's what I was trying to explain in anticipation. I understood where you were going with that. We don't know how long it will last, because a lot of it has to do with how persistent the virus is, right? How persistent the virus is in the world, in the community, in society. And we don't know that. Like, if we, in the most perfect circumstances, could vaccinate everybody in the world, or at least a large proportion of people in the world tomorrow, then this virus would be eradicated from the face of the earth. And we wouldn't need to ever get vaccinated again for this virus, right? If it takes 2, 3, 4 years to vaccinate enough people, it's very likely that in that 2, 3, 4 year period of time, we're going to have a new strain that will adapt to the vaccine, right? That will have a new protein that will no longer be affected by this vaccine, and we'll likely have to get a new vaccine, just like we do with the flu. Okay. So in short, don't know the answer to that until enough time passes. But I think it's going to be likely that this is going to be more likely closer to the flu. It may not be each year, but it may be every other year if we don't ramp up our vaccine administration procedures here in the US and around the world. Right now, vaccine administration is so slow that it's likely we're going to give the virus time to continue to mutate.
Okay.
Okay, so this question around when will it be ready for the general public? And I think you guys have been watching the news and have heard that they're sort of behind schedule in vaccine distribution and readiness at the state and county levels. They were anticipating in early December that probably by mid-January, late January, we'll begin identifying high-risk individuals in the population, and not just first responders, but also patients, long-term residents, and other individuals who might be higher risk, as well as essential workers as the next tier to get vaccinated. Again, I think those dates have all been moved back a little bit. So instead of mid-January to the end of January, we're now looking at probably February before we start getting to the second tier of vaccine administration. And so the CDC now does a nice job, cdc.gov, of defining what they recommend as the 3 tiers of vaccine administration and distribution in the US. And I will refer you to the cdc.gov website to define those 3 tiers. But in general, they've taken the first tier being first responders and healthcare workers, the second tier being long-term care residents and essential workers, and then the third tier being the general population, and with a bias towards those general populations with comorbidities and high risk for bad outcomes. So we're probably pushing it at least another month before your Kaisers or others have enough to begin distribution to the general patient population as a whole. Okay, so that is what I had prepared. We talked answered a lot of the questions along the way. Let me go to the chat to be sure I didn't miss things in the chat. I think I covered that in the chat. Good to come back from a slide presentation and see so many of you. I see some of you with beautiful pictures, but no one live, and that's okay. But I will ask what questions or any questions folk might have. Yeah, that's right. I got some people now just popping up like that. I appreciate that. I don't feel so alone.
One question, my last question, Doctor. If you get the first vaccine from one manufacturer, can you get the booster from another manufacturer? If it's because with production right now, it's not going as fast as it should. So what if you got the first and there is no more, but the Moderna is available? Would they give it to you? No? Okay.
No. So that's a good question. They are similar types of vaccines. You're absolutely right. They both are mRNA vaccines, but they are unique and different. If you both will require 2 separate doses, and whichever one you get first is the same one you get second. Okay. So if you get one from Pfizer and you go to another health plan, or your health plan decides they now have Moderna, they bought some Moderna, they will have to give you the Pfizer vaccine as the second one, right? And if they run out or somehow something happens, there is a protocol for sort of starting over, if you will, with a new vaccine. But whatever you start with is what you finish with. Okay, that's very clear.
Thank you.
Okay.
Okay,
Yeah.
I got a question.
Hold on, Donna.
Okay.
I want to make sure. I want to give others a chance. If anyone else have a question?
Yes, Dr.
Before. Yep.
Okay, Dr. Harrington, I'm taking my second shot on Friday. And also next week, I'm due to take my monthly COVID test. Would a shot show up as a positive in a COVID test, the PCR test?
Oh, that's a great question. So we covered the 3 basic types of testing before. And so I'll reiterate that real quick. 3 types of tests. The first test is a PCR type test, which is a gene amplification test. That test specifically tries to detect active duplicating or replicating virus in your body right now. Okay. Then there is a protein-based test, number 2, which indirectly detects virus. And then there's an antibody test, which doesn't tell you whether you have infection now. It just says you've been exposed at some point. So we know for the most part that if you get a vaccine, that it is very likely that your antibody test will turn positive. Okay. However, your PCR test should not become positive. Your PCR test should still be negative, because remember, the mRNA, the messenger RNA, the construction worker, is not building a whole house. It's just building a little bathroom, right? The PCR is looking for the whole house. Okay. It's looking for the whole house. So the mRNA, when you get the vaccine, just actually has your body recognize and build a little bit of protein, and not the virus. So if you get a PCR test, that PCR test should still be negative. If it's positive, David, that means you got the infection at some point, okay, or you have it right now, if your PCR is positive. So when your PCR is positive, it means you are infected, either now or very recently. Okay. It's a good question, and it's worth reminding, because oftentimes people ask the question and they use the frame of reference test in the question, but you have to qualify the question with which test we're talking about, because the answer varies based on whether we're talking about, for example, on one extreme, the antibody test, or the PCR test on the other extreme. Okay. Very good. Very good. So good to see you, Hope. Haven't seen you so long. Okay. Other questions before I let Donna back in?
We
Going
should have.
once? Going twice? Okay. Oh, I have someone. LG somebody.
Oh, wait. Sorry.
LG Stylo. I don't know who you are. Go ahead and speak up. Unmute yourself and speak up.
Okay, can you hear me?
I can.
Okay, this is Cynthia Etsy. Excuse me. I was wondering, oh my goodness. The time frame for the test to be administered to the general public.
The test or the vaccine?
The vaccine. I'm sorry,
Yeah.
the vaccine.
Mm-hmm.
Since it's so far ahead, how will that, I mean, because I understand, just the professionals, the doctors, nurses, and those who actually need it are being vaccinated first. But the general public, it won't even become available for about 4 or 5 more months, right?
Well, we're
So,
hoping it's not that long. The first tier of the general public might be as early as February, because we're now trying to identify very high-risk individuals in the general public, like long-term care facility, right? Folk who are older with chronic diseases, et cetera, right? So that first tier, hopefully in February would be identified. But if you talk about the general walk and talk in public, like my kids and everybody else, you're
mhm.
right. We're likely down to 3 or 4 months before that happens. You're absolutely right about that.
So I've been noticing in the news that, you know, the people dying from this disease are like getting younger. First, they were worried, more about just the underlying causes, the respiratory illness, people and the elderly. But now it seems that the younger ones are getting it and dying. So what I'm wanting to know is that, since it is so far in advance, and then you have to wait so long to get the second dose, how effective is that for, or how helpful is that actually for the general public?
Yeah,
Because I agree that the healthcare professionals and the emergency people should get it first. Unquestionably, you guys are in there all the time. But for the general public, how helpful is that, since it's so far away?
Yeah, so let me, if I can, try to answer that, and I'll just first say I completely agree with you. Like, the real way to do this, if you have the right infrastructure, is to distribute as much vaccine as quickly as possible to as much of the population as possible over a very short period of time. But that requires infrastructure to do that, right? Which is not federally, how shall I say, supported. It's actually state and local municipalities supported. So that becomes just sort of how people are populated and situated to do just that work. So I agree with you 100%. Like, if I could snap my fingers, we would just, vaccinate everyone who wanted to be vaccinated over a really short period of time. We would save a lot of lives and potentially drive the virus out of the communities with herd immunity. Okay. The more the vaccine distribution is protracted, as you're describing, the longer the virus is with us. 100%. And the only thing that we can do to change that, as citizens, we can't do much. Even in my role in healthcare, and I have some administrative responsibility in Department of Public Health for Los Angeles County, I can tell you we're at the mercy, like we're literally at the mercy of the vaccine being distributed to the state and then to the county. So we only received a limited number of vaccines in LA County to then be divided amongst the hospitals and the health system, right? So the sort of the bottleneck, if you will, turns out to be the readiness of the states, if you will, to receive large, and when I say large, I mean millions of doses of vaccine. And I can tell you, even in December, when we knew we were going to get the first aliquot of vaccines in LA County, people were scrambling to find deep freezers to store the vaccine. We didn't even have enough space initially, right? So you have to understand there's so many infrastructure issues, and from a citizen layperson standpoint of view, you want to just say, like, this can't be that people haven't planned better for this, but it's literally how it is. And if you listen to the BBC or some international news, you'll hear about other countries, right, who seemingly have distributed millions of more doses of vaccine, right, than the US. And some of that has to do with the infrastructure and the sizing of their public health and health system to their population compared to the US. It's very different, very disorganized, very delegated and regional decentralized as opposed to coordinated, as it is in many countries around the world, where you have one system, one coordination, right? In the US, you don't just have 50 for 50 different states. You've got 50 in every state. Does that make sense? I mean, it doesn't make sense, but that's how it is. And that's what actually has allowed for this poor planning and distribution delay that currently exists. So I'm just explaining the reality. There is no sense to make out of it, you would think, but it's why we're in the predicament we're in, and that I can explain really well. Why it can't be fixed easier has to do with the republic idea of each state, right? And each governor has their own autonomy and their own authority, and they translate the rules and recommendations from the CDC or whoever by their own standards and by their own sort of values. That's why you have, you go to Arizona, you can be in Arizona and have in-restaurant dining in Arizona, right? You come to California and restaurants are closed up, right? We're in the same state, same disease, same infection, but people are handling it completely differently, right? And that's because of a protection of state rights and freedom. That's called the United States of America, right?
Right.
Okay.
All right, Doc, you got my attention.
Hey, brother Walker, man, it's been a
How are
long
you?
time, man.
It's been a
I'm good,
minute.
man. How you doing?
I'm doing well. It's
Yeah.
good to see you. How are you?
I'm good. Good seeing you, brother.
Good. You got my attention when you started talking about the contractor and the and the blueprint. I've got a question as far as this Moderna and the Pfizer vaccine itself, the base for it. I mean, I've heard things like part of the creation is from fetal remains and that kind of a thing. Can you help me out on that?
Nah. Okay. So, great question. And here's the challenge. I'm going to answer your question, but I'm going to say this as sort of a warning, right? That because of our ubiquitous availability of information and readiness, ready availability of information on the World Wide Web, there is absolutely no fact checking. There's actually no screening of information. And now people are so good at packaging information in such a way that it's believable that you cannot discern what is poppycock versus what is truthful, right? And that's even more so the case in social media. So I just want to say that I think it's what you raise is a really important question, and it raises the issue of that there's so much information that's out there, it's hard to know what to believe. So the mRNA that was used was engineered, okay? It's engineered, and then it was packaged in lipid bilayers, okay? Now, lipid bilayers actually are taken from usually fetal yolk sac and stuff like that. Okay, it's not like because it's a fat compound that is when we talk about embryonic tissue, it means that it's so I don't want to say immature, but it's so fundamental that all of us will recognize it and not reject it. Does that make sense? Like the reason why our bodies actually reject something as foreign is because we've kind of either grown out of it or we've never been exposed to it. When you have sort of what we call this is totipotential, TOTI, meaning that something is so basic, something is so nascent at the beginning of life, if you will, so at the embryonic stage, that's something that all of us, right, it's common to all of us, okay? And so what people have done is they've taken information about embryonic lipid bilayers, okay, and they've gone like, oh, that's fetuses. No, it's not the same thing. That's fetuses that actually are dead, and they've taken that dead stuff. No, 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 no. This is actually stuff that's done in a lab. This is stuff that you actually grow in tissue culture in a lab, okay? And you produce in little plastic Petri dishes, okay, in a lab. And it's grown and multiplied in a lab. That's why the production of the vaccine took a few months, right? Because you actually had to grow it, harvest from one dish, re-implant, grow it again, multiply, 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 multiply. All this is done with smart, sort of what we call biotech engineers in a lab and packaged in a lab and then put into, you know, a tube, a test tube, if you will. That's it. There's no dead fetus or carcass that was sacrificed or derived in the process and engineering of this at all.
All right. Well,
It's a really important question because it's part of what that information's out there.
yeah, I appreciate that. I appreciate that because I was really concerned about the contractor trying to alter the plan there, and you really helped me out with that. So
yeah, so again,
I can understand as far as everybody being able to use that because it's a part of the beginning of life.
Yeah, but we're talking only about the lipid, the fat, not the mRNA. The
Okay.
mRNA is engineered. The mRNA is engineered. It's not like some mRNA from some animal or some human. The mRNA itself is engineered by some smart dudes and girls. Okay, I mean, just some smart guys and gals like can engineer the messenger RNA, but then it has to be packaged in something that will be accepted to us, right? And that's what we call, it's like a fat ball, if you will, right? It's like a lipid fat ball. And every cell in our body is made of a wall, okay? Like here's the inside of the cell, and then every cell has a wall, like a sphere, like a ball. The wall is made mostly of fat with a little bit of proteins in it, if that makes sense.
Okay.
So the wall is a fat wall, and what you want to do is package the mRNA in some fat that can easily get in and not be rejected.
Okay.
Okay. So the mRNA is engineered to do just what the construction guy does only, right? Doesn't get integrated into your DNA, doesn't become part of the blueprint at all. It just is like the hammer, you know, that is the tool that gets used to do the work, and then it goes away. That's it, goes away, right? That's it. And the fat dissolves and it's not a big deal.
That's a,
You just muted yourself, brother.
I said,
You just mute yourself.
you just explained it better than I've ever heard it before. That's what my son Cameron does. He's a bioengineer and nano. So it sounds like some pretty cool stuff, but building the body, that's definitely some cool stuff.
Yeah. Yeah.
Thank
I appreciate
you.
the question. No, I appreciate that. And so good to see you.
Thank you. Good to see you as well.
All right. Any other questions?
Yes. Dr.
Otherwise,
Harrison.
yes.
Because they're putting us into quarantine, if everybody shuts down and be inside and we have the virus out there in the open, would it just die because it has no place to go?
Yeah. So
back out, then
yes,
it grabs us again.
Yeah, sort of. Like if what you're suggesting to do is very difficult for people to adhere to for a prolonged period of time, you would actually have to not only stay quarantined, but remain quarantined and out of contact with people for a long time, meaning probably a few months, because you think about the half-life. And anyone who's in the hospital who's sick, who gets well, would also have to remain in quarantine, right? And if everyone did that for a long enough period of time, you could eradicate the virus. But you would actually have to eradicate the virus completely, because the millions of people infected in the United States started with one person. Remember that. Like one person, likely, who came to a scientific meeting in Boston. One person. So it only takes one to get it all started, if you will. So you really have to do some massive quarantining for a prolonged period of time. So our best chance at this point is really, quarantining while we wait for mass vaccination and or sort of natural immunity. That's our sort of best chance at this over the next several months. Okay. In the meanwhile, you got to stay prayed up. You got to stay healthy. And that means exercise, good diet, and as Vina would say, with the right mindset and wellness mindset, because all those things will affect your immunity and your ability to fight an infection if you were to get it.
But
Let
Daryl,
me, yeah.
let me, excuse me. Didn't finish answer my question from the beginning. Okay, you said exercise, and I know that's a crucial part of trying to be when you're on the mend. But if I can't walk from the parking lot of Target in to pay my bill, and then I have to go back to the car because I'm winded, how am I supposed to walk to try to get better? What can I do? Or will this just go away in time?
Yeah, so let me say that if you've already been infected with the virus and the virus is now just taking its toll, you're no longer infected. Like over a period of time down, you will no longer be infected. You'll have immunity, but you'll have the residual effects of the virus on your body. Okay, and that's going to include you being tired, fatigued. In your case, for other people, it might be loss of smell and taste. For others, it might be a headache. For some, it might be a rash or a blood clot. It may vary from person to person. So in your case, yeah, you kind of have to push yourself as far as you can, then rest and be patient. Some of the things that may require more energy per level of activity, if walking is really hard for you, then for example, riding a bicycle, even a stationary bicycle, might be easier than walking. And then you just have to be very patient and build up to that, if you will, right? But what I would say is that it's really important for you not to succumb to being tired by just staying in the bed or staying in a chair. You still need to be upright and active and engaged. And if you can't walk but a block before getting tired this week, well, next week you'll be able to walk 2 blocks, right? So just be patient, and it will slowly improve over time, right?
Okay,
So
well,
that's for sure. There's no cure once you've gotten it. There really is no real cure per se at this point. It really is now allowing your body, the miracle of your body, to recover, right? And our bodies were perfectly designed to adapt and recover, but sometimes it does take some time.
yeah, I
Okay,
guess the older you are, the longer it takes. So therefore, I
that's
should
very
start,
true.
huh? That
Yeah,
is
that's very
true.
true.
Yeah, okay.
Yeah,
So it's okay if I get out and just start walking little bits, and then every day
absolutely,
little bit more, and it'll get better through time.
absolutely.
Thank you.
All right. Okay. Anything else? It's 8:30. We've gone beyond the hour a little bit. We've had a good discussion. I really appreciate seeing some folk that I haven't seen, like Elder and Mrs. Walker. Oh my goodness, man! I remember singing with that group. I know you guys remember us singing like the Temptations. Okay. So I missed that group tremendously. So just so good to see you all. Until next time, in 2 weeks from now, we'll have another health topic. And again, depending on what's going on with COVID, we either won't talk about COVID because there are other things I'd like to talk to you about beside COVID that actually hopefully can improve your health and well-being. But if things are really just sort of hitting us hard with COVID, then we'll focus on that. And so until next time.